Happy Friday, everyone. I'm going to be talking about cancer care today with one of my colleagues and good friends, Steve Nimer. Hey, how you doing?
Hey, we did it.
We did. I was just saying that it's this is harder than curing cancer, but I feel like this interview is going to be easy now.
I think we took an extra 6 minutes, and if we could cure cancer in 6 minutes.
Well, listen, Steve. Thanks for joining us. I know how busy you are. I'm going to do a brief intro for those rare people who may not know who you are while we're waiting for everyone to log on. Real pleasure to talk to my friend and colleague today, Dr. Steve Nimer. He's a world-renowned cancer specialist, going to be talking about the future of cancer care. He is director of the Sylvester Comprehensive Cancer Center here at the University of Miami. It's the only NCI-designated cancer center in South Florida. Huge honor, and that is 100% Steve Nimer's leadership, his vision. He came here several years ago. That was his goal. He did it. So really a real feather in his cap, and we're all very thankful. Steve is a leading hematologist, molecular biologist, and bone marrow transplant physician by training. His background is very impressive. He was at Memorial Sloan-Kettering Cancer Center for nearly 20 years, where he held the Alfred Sloan Chair and served as head of hematology oncology, as well as vice chairman for faculty development. He also served as a member of the Sloan-Kettering Institute for Cancer Research and was a professor of medicine and pharmacology at Cornell. Dr. Nimer has conducted extensive clinical and basic science research into the treatment and genetic basis of adult leukemia and bone marrow failure states, authored over 200 scientific publications, and has received numerous awards for his research, including the prestigious Irma Hirschl Career Scientist Award. As background, Dr. Nimer graduated from MIT, received his MD from the University of Chicago, completed his residency and fellowship in internal medicine and hematology oncology at UCLA, joined the faculty at UCLA, and then went to Sloan-Kettering. Dr. Nimer has been elected into the prestigious American Society of Clinical Investigators and is a fellow of the American College of Physicians. He serves on the editorial board for several medical journals and is on the medical boards for the Myelodysplastic Syndrome Foundation and the Bone Marrow Foundation. He's also chairman of the medical advisory board of Gabriel's Angel Foundation for Cancer Research. And like I said, here today to discuss the very important topic of cancer care and kind of what the future holds. So again, Steve, thank you so much for joining us.
Thank you, Rick. It's a pleasure to be here. Sorry it took so long for that introduction.
That's all I know. It's just, way too many accomplishments. We'll have to dial it down next time. Well, listen, let's start with just basic questions. People want to know, why is cancer such a difficult condition in general to treat as opposed to heart disease or stroke?
Yeah, I think, first, cancer is a disease of the elderly. And so, in essence, the cancers in your body have decades and decades to develop. And so, we understand that cancer is a very complex disease. We used to think that there was a single cell that you could target, and we now understand that cancer is a collection of different cells with different properties. And if you have to kill them all, it's a more daunting challenge than we thought. Gleevec was a huge advance 20 years ago, tyrosine kinase inhibitor used in chronic myelogenous leukemia to target BCR-ABL kinase. And that drug is a miracle drug. And so we thought that other kinases would be similar. So in part, cancer is complicated. And the other thing is it's a part of our bodies. And so we've learned, like with the Pfizer and the Moderna vaccines, that if you understand the virus, which is extrinsic to our body, and you get your immune system to recognize an important protein on the virus, that you can block the viral infection. But our own immune system can't really recognize our own cancer and kill it. The cancer has already done the job of evading our immune system when it comes out.
I mean, that's a very, very good point. The fact that it's part of our body. So you're trying to activate the immune system, and we'll get into that later on, but the whole concept of like immunotherapy, having the body recognize the cancer as foreign, is a real, that's a great avenue for success in the future. But do you think we've made good progress in the last 2 decades when it comes to cancer care?
Incredible. Incredible. I think people are living longer than ever before. About a year and a half ago, the NCI announced that the average person diagnosed with cancer will now live more than 5 years. And so when I've lectured in the past, I used to ask a trick question, which is, can you name one cancer that's curable now that wasn't curable 20 years ago? And the answer used to be mantle cell lymphoma because it didn't exist as an entity 20 years ago. But all the others, testicular cancer, childhood leukemias and things, 25, 30 years ago, we could cure a small fraction. We now cure a large fraction. But now you can say, for instance, metastatic melanoma, Jimmy Carter being a great example. He had melanoma in his liver and his brain. He got immunotherapy and he was cured. And that never happened before. And so we're making great advances. Lung cancer, we're curing people with advanced lung cancer. And so these are things that you mentioned, immunotherapy. They've been fundamental to the treatment. And the other thing is that the treatments are much less toxic. As a surgeon, I'm sure you appreciate that the surgery in combination oftentimes with other treatments, chemo and radiation, is extending people's lives. And so I think as physicians, we're working much better with each other to coordinate the care. And you mentioned the NCI Designated Cancer Center, and one of the key attributes of ours is that we work in teams. And so we bring together the best minds and multidisciplinary approaches to cancer.
So let's talk a little bit about the NCI designation, because it is such an important designation. And again, we've all worked so hard under your leadership to get it. What exactly, for the layperson, what does NCI designation mean? And what does it mean not only for us, but also for the patients and for the future of cancer care?
Yeah. The most important immediate impact that it has is that there are drugs and treatment plans that are only available through the NCI, the National Cancer Institute. And so those treatments are now available at Sylvester, so that people who live in South Florida, and there's over 6.4 million people who live in our catchment area. And so we've made this available now to a huge number of people. Treatments that were never available in South Florida, people had to go, either leave the state or go to Moffitt. And so it's really been a huge thing. Cancers are not only complicated and need multidisciplinary treatment, but often the treatment continues for months or years. And so to coordinate that care requires an institute. The other is it immediately gave us $10.5 million. So the grant provides $10.5 million. The state now chips in another $1 million, so that's $5 million. And we've been able in just the first year to get over $1 million of supplemental funding. And so we're getting more money for cancer research. And, it's one thing to say that we're great, okay? Anybody can take out an ad in the newspaper. Anybody can start a cancer center. There's no requirement for that. And so to distinguish us from the other thousands of cancer centers around the country is that we have the NCI designation. It was referred to as the crown jewel in the nation's efforts to combat cancer. And we're proud of the designation. And of course, it elevates our bar for our own expectations for ourselves.
Yeah, I mean, it's a wonderful accomplishment, and I'm glad that you got a chance to kind of talk about what that means for the patients and all the comprehensive care that goes on here. What would you say is the biggest challenge facing cancer researchers moving forward?
People like to talk of low-hanging fruit, and I remind everybody the low-hanging fruit has been plucked. Okay, so the work that we have to do is very much more complicated. In the old days, there was like one treatment. GI cancers were given, patients were given 5-FU. Okay, it didn't work very well. So if you had a drug that was better than 5-FU, it wasn't that hard to show it. And nowadays, the treatments are rather effective. They just don't work long enough, many of the treatments. And so there's not good predictive models. And so one of the things that we're very focused on is what are the surrogates, also called a biomarker? How can we predict who's going to do well? Whether it's going to be genetics or epigenetics, whether it's going to relate to your pharmacology, the way we give the drugs and things. But if someone's going to respond for 9 months to a drug treatment, how can we distinguish that from somebody who's going to respond for 5 years? And we haven't really been able to do that sort of thing. And I think that's the biggest limitation. Patients always ask, why did the drugs fail? And for the most part, we can't answer that. With the tyrosine kinase inhibitors, we can, but for others, why did the treatments fail? And so we're very focused on some very difficult to treat cancers, brain tumors, pancreas cancer, acute leukemia. We want to show the world that we're not afraid to tackle the most difficult cancers, but it's complex. And the other part that the NCI designation helps us with is we're not going to cure cancer by ourselves. We have to work together with our colleagues across the entire University of Miami and at other universities. We have a great relationship now with the College of Engineering here. And also we've developing one with Marine and Atmospheric Science. And we have relationships with Sloan and Dana-Farber. And these are the working together. That's where we're going to make great progress.
Now, like you mentioned, difficult to treat cancers, and we'll talk about rare cancers as well. If a cancer is rare and there's a few patients overall that have it, talk about the role of real world data, meaning that typically randomized controlled trials are the gold standard. You basically prove a drug works, it's safe, and then you release it. But for rare cancers, there's been a push to do real world data where it's still unproven, but you basically collect real world data in real time to figure out if it works. Is that something you guys are really pushing ahead?
We're very excited, and we've tried in a few different areas, some work with City of Hope, some work with Moffitt. How do we get the data in a usable form, what you're calling real world data? How do we really know the outcomes? So many of even the randomized trials, sometimes in the phase 2 trial, there's a control group of historical controls. And then it turns out that when you do the phase 3, the historical controls were not a good control set anyhow. And so I think that your point about real world data is really important. One of the things about our cancer center is the tremendous diversity in our community. Our clinical trials, we enroll about 45% Hispanic patients, 20% Black, so about a third Caucasian. And the data needs to be filtered also through a lot of other lenses besides the cancer. And as you say, for the rare cancers, not that easy to come about that data. But I think machine learning, artificial intelligence can help us and find signals that we may not otherwise find. And again, for some of these cancers where there's really not much available, something very promising without a phase 3 trial is the way to go. Patients, the number of people in the United States with cancer who participate on clinical trials is very low. And part of the reason is a lot of patients don't want to be on a randomized trial where the doctor can say, one of the options you're not going to get the drug, right? So that's not that easy for patients. And it's not that easy for the doctor either. And so, but it's the gold standard. And so we've got to find ways to enroll all these people on different trials.
And you mentioned clinical trials. Now, everyone uses that term broadly. How important are clinical trials towards pushing cancer care forward? And should every cancer patient strive to be on a clinical trial?
There's not a clinical trial for everybody, in part for some archaic reasons. So one of the things that we've done over time, there's Friends of Cancer Research have pushed for this. We sometimes decide who's eligible and who's not, this amount of kidney function, this amount of liver function, this and that. And some of those things may not be important at all. And so we want to liberalize who can go on a clinical trial. I would say if you have early stage Hodgkin's disease and you have a 98% chance of being cured, not a big deal if you get the conventional treatment. But the other treatments, oftentimes they're not adequate. They don't control the disease long enough. And what was astonishing, there was an article on the front page of the New York Times a couple of years ago about ovarian cancer, where at the treatment that's recommended, and they determined that 40% of women were getting the treatment that was recommended.
Hmm.
And so besides clinical trials, we have a lot of educating to do, both of patients and the doctors in the community, that some of these treatments are far too complicated to give in a community setting. But we've got to engage the community physicians in research and, and work with community physicians so that people can get on trials. Sometimes breast cancer, what's the duration of aromatase inhibition that you should have? Is it 3 years, 5 years, 10 years? And we're not going to get at those questions unless we ask people to participate in some pretty straightforward clinical trials.
Now, the other question is, how do you balance prevention versus treatment? Obviously, both are very important. In your estimation, what is the correct balance? Is it 50-50 between the research that goes into treatment of cancer and the actual prevention of cancer?
The problems, we need to prevent cancer fundamentally. Some of the things we know: cigarette smoking, we understand obesity, alcohol intake and cigarette smoking, and for some cancers. And then the whole early detection, pap smear, unbelievable, right? How can we should prevent women from getting cervical cancer because we could pick up precancerous lesions, skin exams, all these things. So prevention is key, but the problem is prevention trials are difficult. This is an area where, everyone has an idea. So if you ask people, and I love to ask people, what medications are you taking to prevent any diseases? And people say, I take a low-dose aspirin, I take a statin, I take vitamin E, I take this, I take that. And then if you ask, vitamin D now is a big thing. And then you ask people the dose, and no one knows even what's the right dose to be taking. So the fact is that the prevention field still has a long way to go. Everyone's got an idea. You look on the internet, fruits are bad, fruits are good, vegetables are good, vegetables are bad, carotene is bad. And so the problem is that it's a bit more a morass. How do you navigate? And every patient that gets cancer has a lot of friends, and each friend tells them something different. The treatment, the NCCN guidelines or other guidelines, it's pretty well established what's the proper treatment for patients with many diseases. And so prevention is just not so clear, and you need to be creative.
And you mentioned earlier about using AI to look at the data and to help push cancer care forward in terms of, predictive models. Can you just explain a little bit how the artificial intelligence is incorporated in data analysis and what the future holds with that? Sure.
So one project that we have ongoing relates to mammography. So, in this modern world, there's still things like radiology and pathology are still to some degree visual specialties. And so when you look at a microscope slide of a brain tumor, you see something different than I see. When I look at a leukemia, I see something different than you see. But what's on the slide is the same. You and I are looking at the same data. So what artificial intelligence would do is it will provide the knowledge that's gained, that you have gained over decades, or that I've gained across all the things. And maybe there's, we've had discussions. DNA sequencing, as inexpensive as it is still not available in many countries. And so maybe your slide can be looked at with artificial intelligence, and we can figure out, that you have MGMT methylation based on the appearance of your microscope slide, because someone with a computer has done all the image analysis, looking at individual pixels, and figured out there's a signal in there that your eyes and my eyes would never see. So,
I mean, it's such amazing technology, and seeing how that's incorporated obviously is very exciting for the general public. Another big buzzword used in cancer, or buzzwords, would be quality of life. I think most of the treatments are measured in terms of quantity of life, overall prognosis, extension of life. But I think any cancer patient would tell you that the quality of life is just as important as quantity of life. How are you guys measuring quality of life? And is that integrated into overall pushing cancer care forward?
yeah. I think of this a little bit. So with treatments, is sort of risk-benefit ratio. So if you told me that my cancer could be cured, as a patient, I'm much more willing to endure some side effects. And as a doctor, I think I'm much more willing to recommend something that has some side effects. And if you're talking about prolonging life by a few months at the risk of making the quality of the life much worse, everyone will have a different opinion as to where to draw the line, but people will draw a line there as to what's not in the interest of the patient. And so I think that, what we have is an opportunity. We use the standard scales for quality of life. I've had a technical moment here. I think my lights went out. I'm not moving.
That's all right. That's all right. We can still see you. It's all good.
So it's pretty interesting that we measure quality of life with various scales. I think one of the things that we're doing, Frank Pinedo at our place is a leader in patient-reported outcomes. The doctor, you see this, I see this. When patients come to us, they know that if they have a lot of symptoms, it may mean either that the treatment's not working or that they may not be a candidate for the next treatment. And so the patients minimize all their symptoms. Doc, everything's going well. And then the partner or the spouse or the family says, actually, he's sleeping eight hours in every afternoon or whatever it is. And so I do think that the way we've measured quality of life is been a bit flawed, because the patients want us to say you're doing well and we can keep the treatments going. And so they underestimate what they're actually experiencing. And so capturing the quality of life properly, and really important. There's 16 million survivors out there. And so we can't just think of quality of life during the treatment, but people afterwards. And people have neuropathy or cardiac problems or renal problems, things like that. So I do think that now that we have more effective drugs, we can start thinking about the least toxic approaches to get the good outcomes.
Yeah, I mean, it's such an important topic. One of the big things that I've seen over the last 5 to 10 years is people understanding that not only is every type of cancer different, but every person's cancer, even if it's the same type of cancer, is different. So talk a little bit about patient-specific therapy, targeted therapies. These are all buzzwords that have really come into play. Talk about how personalized medicine is going to play a critical role moving forward.
Yeah. So whether it's called personalized or precision medicine, as a medical student, I was told to treat every patient as an individual. Everyone needs their own approach, whether it's cancer, it's not cancer. And so some of these are principles that are just part of being a doctor. But in general, what it refers to is, can you understand this susceptibility of someone's cancer, sort of the Achilles heel? Can you find that quickly, and can you target that? And therefore you cripple the cancer, and then it can't grow anymore, it dies, and the patient is cured. And so this is focused a lot on the mutations. And one of the things that we know is sometimes if two mutations never occur together in a cancer, that's because the cancer cell couldn't survive if there were two mutations. And so what we do is the cell has one mutation and we block the function of the other gene. And then suddenly the cancer can survive. And I think that's an approach that is generally applicable. If you really believe that every single patient would benefit from a different treatment, how would you ever figure out who should get what? I mean, there's 500,000 people with cancer in the United States every year, and you'd have to be, more than a genius to figure that out. But fundamentally, the cell has to survive, the cancer cell has to grow, and growth and survival are things that are very common to many cancers. And so there are approaches that work across the board. You know, there's a new drug called venetoclax. It was approved first in the lymphoid cancers. Now it's approved in the myeloid cancers, and it works in many, many settings. And so it blocks the BCL2, the survival signal that gene sends to a cancer cell, and then the cancer cell dies.
It's wrapping up here, Steve, because I know that you had a super busy schedule. What would you say are the 3 most promising avenues that we should look forward to in the next 5 to 10 years when it comes to cancer care?
You know, number one is to continue the immuno-oncology, revving up your own immune system so you can fight your own cancer. And the part of that is going to be, there are tumors that are recognized, cancers that are recognizable by your immune system, and there have been others that are still not recognizable. And I think there's going to be a lot of work on how to make cancer cells recognizable. And so, and that may involve epigenetic drugs, or it may involve drugs that target RNA, but immuno-oncology is going to be key. The other, I think, is going to be imaging. Many cancers are curable if they're detected early enough, and yet we don't have good ways of doing that. So I do think that there's going to be blood tests that may diagnose cancer. There's going to be other types of imaging that can be done. So maybe you find a protein in the blood, or you find DNA in the blood, and we can diagnose cancer earlier and intervene. I think that those are fundamental new approaches. And
well, Steve, I would say, sorry, go on.
Third is just disseminating the information that we all have. It's really important, getting second opinions, seeing the experts in the field. We all specialize and super specialize in things. There's so much knowledge there. So I do think that the third revolution is going to be information.
And kind of making sure that everyone is at the same point in their knowledge base, that an advancement that happens at Sylvester quickly gets disseminated to other NCI cancer centers throughout the country. Is that basically? Exactly. So we're all working together, not against each other. That's the key.
Right. And we do. The patients all want to know. They understand there's some competition to make discoveries, but in your field and in my field, we know all the key people. We're talking all the time. People say, what's happening, and you can learn. And when I get a call about a specific patient, I can call my buddies elsewhere and find out if there's anything that's new on the horizon that I may not be aware of. So we do work together. I think it's an important message to get out to the community.
Yeah, I mean, 100%. Steve, it's I would say that it's very exciting times. Just like you said, major advancements in terms of cancer care over the last several decades. No doubt that is going to continue in terms of other types of cancers as well. Thank you for everything you do, not only here at UM and Sylvester, but for all the patients here in South Florida. Again, you're just a huge role model, a great leader, and again, thanks for pushing your vision and really making this a leading cancer center.
Thank you for the interview, Rick, and all you do to help patients and for our community.
All right, Steve, you have a great afternoon, okay?
Okay. Thank you, Rick.
Take care, bud.
Bye-bye.